intervention, so I'll be speaking on the anesthetic management and a little bit about the mitral clips. So, like reality in life, first the cardiologist was there and then the surgeon, and lastly you were in the operating room with the anesthetist, so I'm here. So we'll just talk about minimal invasive mitral and the mitral clip intervention. What is basically you need to look about from the anesthesia point of view. So it's a very basic talk, but these are something which can really contribute to your cardiological and the surgical management. I have no conflict of interest, but I have some videos from my previous employer from Heart Center Leipzig and from Toronto and presently where I'm working. Firoz has already talked about what the setup should be, but this is usually the typical setup what you get to see. But what is very important at this point of time, what I really want to caution you is this part where do you have a, you don't see my pointer. Do you have a pointer? Yeah. What is important to see that this sometimes comes in this area may be a little detrimental for your thing. There's cases where has been accidental extubation during the operating or when the surgery is going on. So this is something you have to be careful where the surgeon is manipulating the camera. They may actually take your tube in hand and try to pull it out. So I had personally experienced one case where the patient was accidentally extubated during the surgery. Like the surgical point of view, there is optimal visualization, which actually Firoz already told. There's no sternotomy and it's a minimal access. But what is very important from our point of view is the quicker recovery. From patient point of view is improved cosmesis. And this is something I really, this is what the surgeons actually give it as an advertisement, but if you compare it to a sternotomy, this really can be a post-operative, a big problem for the anesthetist to take care of the post-operative pain. So that can be really challenging. Surgical trauma decreased, yes, I agree, but decreased post-operative pain, I have some slides on that which we can discuss. And obviously, it's a better marketing from the surgical point of view. So from the anesthetic consideration, in the centers I have worked, unless contraindicated, all these patients are actually undergo fast-track recovery. The prerequisites for fast-track, who is a stalwart here sitting right now, Dr. Enda and his group has actually told, these are the basically 3 criteria. The patient should not be bleeding. There should not be actually very minimal inotropes, and patient is definitely warm before you leave the operating room. So that is the 3 challenges which you face, which is what is in your hands, is this what you can do, and this is also something which is the consequence of the outcome of the surgery, and this is what the surgeon has to take care. So it's a teamwork which you have to put into for taking fast track in person. So yeah, I hope you recognize this person who is in a mask and this thing. That's me in Leipzig Heart Center. So what you usually do is how to keep the patient warm. You have a biohugger in the induction room, so the patient is warmed right during the induction. The temperature in the operating room can be hiked up if necessary. The patient intraoperatively gets a biohugger, and here you can infuse pre-warmed fluids during the operation. So these are the manipulation or the maneuvers which you can really, secure before you have actually started with the surgery. And these are all the intraoperative maneuvers which you can do to take care of the patient leaves the operating room warm, which is 36 degrees in our opinion. So main challenges for the anesthetist, like any other surgery, there's like hemodynamics and volume management, avoidance of hypothermia. This can be sometimes very edgy because the biohugger mats, the surgeons are always telling to shut it off, but you're on the other side of the green, so you have to keep on telling the person has to leave the operating room warm, so that can be a kind of a conflict between you and the surgeon. TE findings, that's very important because without this, the surgeon is extremely handicapped for the entire course of the surgery. And post-op course of the analgesia may be extremely challenging because post-operative course and analgesia is something which is, the person looks, cosmetically very nice, but believe me, that is a more painful surgery than having a sternotomy because you're exposing the intercostal nerves, and that is something difficult which is to treat sometimes. So in monitoring, I'm not going into the details because this is the routine monitoring which you all do. There was a question which from the chairpersons from what's about a double lumen tube. So if you really need a double lumen tube, we have not, in my opinion, you don't need it. But if the patient comes back for a rebleed, that's the time which is enormous help to the surgeon, where you're decompressing one of the lungs, and that's the time the surgeon has a better access to operate than. But in a routine surgery, you don't do it, because in New York and Mount Sinai they used to do it but they have stopped about 3 or 4 years back, and in Toronto they never used it, and in Leipzig also they haven't used it. So this is a contradictory thing, but it is definitely helpful during reoperations when the patient is bleeding, because you can really compress the lung during that time. During the induction room, in the induction room, you do a surface ultrasound to put all the lines, like in the internal jugular and in the carotid. So this is the one which you have to avoid, and this is the one where you have to put, so you can see the wire in that. And once you have the wires in place, the next step is the cannulation. So we have usually a TEE and a surface ultrasound already in place. So that is something which you have to really look before you start the surgery. So like I said, I have to do the talk very fast. So I'll just go into the video where the cannulation is taking place. But remember, at this point of time, the wire has to be controlled, the cannulation has to be controlled, and that has to be done under TE guidance, because if there is a ASD, there is a chance that is going to be landing up in the left atrium. So that can be really challenging for the anesthetist as well as for the surgeon. So here you can see the wire actually going in, and immediately you will see a TE control of that taking place as the wires are going from the inferior to the superior vena cava, and this will be followed by the cannulation, where you can see this is actually about 16 to 18 French cannula from Edwards, which is being cannulated, and the wires are out, the cannula is going in, and this is done during the TE guidance. So that is something which is actually an anesthetist needs to be in the bicaval view, because that's the best view where you can do the guidance. And here you can see, and here you can actually control to what level you can extend the cannula into. And if you have a ASD here, there's a chances that you're going into the ASD. So control of the wire as well as the cannula is definitely a TE guidance which you can do. But before you start that, like Firoz had said, if you see something like this, AI grade 1 or 2, that is something where you have to stop. And a thrombus is obviously, you have to do it under TE guidance, because the reason why is that if you see the aortic root is here is the clamping. If you are clamping and if it's not sufficient with the AI, this surgical field is going to be flooded with blood. So if you really don't clamp it properly, it becomes extremely difficult for the surgeon to operate, because there's going to be a regurgitation blood in the mitral view. So coming to the next, before the first thing, what does the surgeon ask you? There's only one golden question: is the valve repairable or not? And that's where you get the biggest challenge. So you have to, these are actually the steps you have to go through. And like there were questions in the echo workshop, I get a patient with MI grade 3 intraoperative, he is MI grade 1, what do I do? So you have to do some necessary additional maneuvers, pump in with fluids, give some inotropes, kick up the pressures to around about 160 to 180 systole, and then you get to see what's exactly happened, and then you mimic the conditions which the patient is facing every day on a day-to-day life. So this is steps which you have to go through: reconstruction, the findings, and assessment of the LV function. And there's a golden rule by which is repairable, so you go from down to the top. So you have a success rate of mitral repair with the dilated mitral annulus, which the surgeon has already talked about. P2, this from here onwards, it starts getting tricky. So you can see the border like a 50-50 chance. From here onwards, you need the experienced surgeon. Isolated AML prolapse, bilifted prolapse of the Barlow's, that can be really challenging. And then heavily calcified mitral annulus, most of the times they're actually replaced than repaired. Then the next challenge is what classification it is, whether it's a type 1, type 2, type 3. In this course of the meeting, you have heard also. I won't go into the details of that. But what is important to diagnose, and where 3D TE has actually really helped us in the years, is how do you diagnose a cleft? And here you can see a very nice cleft which preoperatively you can detect and tell the surgeon even if it's come for a mitral valve repair. In the type 2, it's a clear-cut show. You have a type 2 prolapse where there is a prolapsing all the segments, and the surgeon actually mimics it in the intraoperative setup with your echo findings, which you really get to see, and that's exactly what the surgeon has found you in your echocardiogram. So echocardiography can be extremely helpful, and it can really communicate with the surgeon even before the surgery has started. So he confirms this, and if it's a mitral, minimal invasive mitral, he can confirm your preoperative findings using the echocardiography. Type 2 can also be a flail. So if you really see a flail in a 3D echo like this, and it can be confirmed using the flail intraoperatively, where you see the two leaflets bulging out into the LA, and that's a very typical finding of a flail. What is challenging, in my opinion, is the next is where you get a restrictive or a functional and a structural restrictive. So this can be challenging for the echocardiographer, where the only way you can distinguish is whether it is in combined flow in systole and diastole. So you see in this type of cases, the systole and diastole flow is actually a structural restrictive. And this is a borrowed video from Narayan Hridayalaya, where we don't get this patient's neuro or rheumatic valve disease, where you get to see this kind of a flow, and that can be a little challenging from a TE point of view. And then what is challenging for us too, that is quite challenging for us as well. What is challenging is for the surgeon to repair this kind of valves. So this is functional restrictive. So there is a chance of there's an ischemic pattern into it. So if there is ischemic cardiomyopathy or ischemic tethering, you can see very well in this kind of a view the tethering has occurred. So actually there is some surgeon who does only a downsizing of the annulus and get out of the operating room, but 30% of the people come back because they're not really addressing what is happening at the level of the papillary muscle. So if you have a tethering height more than 10 millimeters, you have to communicate with the surgeon that the tethering height is more than 10 millimeters, and you have to do something along with just rather than only downsizing. So that can be challenging. And obviously the indentations, these are normal indentations, these are not clefts, so you can visualize them intraoperatively. So you have a clear-cut pattern and your TE findings before surgeon comes into the room. This can take initially in between 10 to 15 minutes, and that is the time you should spend in the intraoperatively before the surgeon comes to diagnose your echocardiography findings. And then in the next step, what you get to see is what you anticipate during the surgery and post-surgery. So what are the possible complications of the repair? So first complication, if you have, is what is known as a SAM, where is the cartoon which shows there's a through the mitral, going back into the aortic valve, and what happens if you have a AML or a PML ratio more than less than 1.4, or a C-sub distance, which I'm going to show you in the next slide. If this then actually goes back into regurgitant flow into the mitral valve. So there are some criterias, and in the SAM constellation from this paper from Maslow in 2006 and Carpentier in 88, they said that for a myxovarus valve, AML-PML ratio less than 1.4, so this is the height of the AML and PML ratio. And if the PML height is long, there's more than 1.5, and this is your C-sub distance, which is 2.5, and that can be actually a contraindication or actually a precursor, or you can tell the surgeon that, you know what, this is a chance that the patient will come back. And this my next slide, I'm extremely thankful to Dr. Enda, where he has showed us with cropping from the LVOT view as well as from the aortic view. This is, I think, in my opinion, one of the stalwarts of echocardiography who has actually shown us this is the piece of tissue on there and post-surgical repair from the LVOT side, and that muscle is actually gone. So with 3D TE cropping, you can actually do a lot, and this is one of the beautiful examples how SAM can be shown, elucidated very nicely in 3D TOE. So before separation, DA the ventricle, myocardial functional status should obviously, and what is the main thing, the question is the patient is warm enough. Don't go out of the operating room if you're planning for a fast recovery less than 36 degrees Celsius. But obviously the first thing what you get to see is if you are faced with something like this, it's the type B dissection where the descending aorta is actually ruptured here. You can see two flaps. And this is actually, it's a long day in the operating room. If at all the patient, that's an AV dissection, which has happened intraoperatively. And again, the same picture which you get to see in 3D cropping, you can exactly localize where this flow is coming from. So AV dissection, in my opinion, is one of the worst complications which you can get. And like what Dr. Davier already told you, if you have a long ascending aorta and the tissue is fragile, there are chances that you will land up with a dissection. Dearing the ventricles is something which you get to see after release of the cross clamps. So if you see something like a ball of air in that, you have to take time. You just cannot come out of the pump like that. You have to extend a pump run. You have to probably give some maneuvers. The surgeon tries to push the table. You do gravity, anti-gravity, and try to fill it up and give some inotropes to get this pump. And when the needle vent is already there, so there's no point taking out the needle vent and de-air, because that's all going to circulate in the brain. And if you see something like this pre-op and post-op, if you see something like this in this area, then there is obviously something going wrong. And you see there are no airs in the ventricle. So if you see there is no air, and this post-op there is in this area, something is come up, then obviously coming from the Leipzig group, you can make out that it's a circumflex rupture or iatrogenic circumflex ligation, which is possible in an incidence of 2 to 4% of the patients. And what is good about this, what you can now with 3D echo is what you can do is exactly visualize. So this is the culprit suture from the surgeon, where you can see this suture is actually cut the flow of the circumflex, and what you have to tell the surgeon, you have to take this ring out and resuture it, and intraoperatively, and you can prevent the time of the complication of the patient going into the cath lab, getting angio, and then see the ligation. So with 3D echo, you can really see if there is a culprit suture, and this is your proximal and your distal CX, where you can make out where is the flow. You can do it also with color flow, but if you really want to pinpoint where exactly is the surgical suture which is obstructing the flow, you can see it with this kind of advanced 3D TEE. So at the end, when you're coming after the bypass, like I said, try to make it the patient as much as, without hyperdynamic LV tachycardia, which may be sometimes challenging. And this I'm not going to, because Firoz has already told you in details. So coming to your question, 3 challenges. It's a meta-analysis and systemic review. So they said with this paper, if you go through, these are the 3 challenges which the anesthetist faces. One is one-lung ventilation, TE, and pain therapy. So TE, I'm not going to go into the details. I've already told you. So going by one-lung therapy, Dr. Bainbridge and his colleagues from London, Ontario, they had done a case study where you can see they have taken about 278 patients on retrospective undergoing minimal invasive mitral valve repair. And they have said, what in conclusion, they could not really detect what is the pathomechanism behind this. Why does the patient land up in pulmonary edema and one-lung ventilation? But what they said that it is definitely unilateral post-op pulmonary edema was independently. They had identified the factors, and one of them is COPD. The patients with pulmonary hypertension, right ventricular dysfunction, or both, and increased CPB time. So these are the 4 factors which actually has contributed to unilateral postoperative pulmonary edema. I had the opportunity to speak to Dr. Ende yesterday. They are presently doing a retrospective study themselves about to find out what's the Leipzig group's results, and probably you will see it in a short time. So unilateral postoperative edema, they also said that further research is needed for a better understanding of the pathophysiology. So at this point of time, you can point out what are the contributing factors, but you can't really say. They have already ruled out that atelectasis was a cause. So my first understanding was atelectasis, but if you have a patient on prolonged CPB, that may be detrimental. Pain therapy, there are 2 ways to do it. I know I either use neuraxial blockade, which we had published in Annals, and using a single shot morphine, using minimal invasive mitral valve. the group from Nuremberg, they published using a paravertebral block. So whatever way you are doing it, ultimately it doesn't have an impact on your length of stay, but it definitely increases, or decreases your use of narcotics post-operative. So the use of the post-operative narcotics in PCA or whatever mode of pain therapy you are using, so single shot morphine or a paravertebral block definitely reduces your narcotic use post-operative. Sorry, I don't have time for mitral clips to discuss in detail, so I won't bore you with that. But there's one thing which I want to tell you. For mitral clip kinase, this is one procedure which you can't do without 3D TOE. So if you are using 3D TOE routinely and you are experienced, then only be adventurous about going for anesthetizing these procedures, because you are faced with challenge every step, and it's a completely 3D TE guided procedure along with fluoroscopy. And I'm sorry, and I have to shut down. I'm sorry about that. Where the surgeon or the cardiologist has actually put in 4 clips for a mitral clip implantation. So this is also it's an exception. Things usually don't happen like that. But in a normal setup, you can do with only 1 clip, but it's a TOE guidance from defining the landing zone to steering to guidance. Everything goes in a phased-wise manner along with your cardiologist's communication along with the surgeon. So what happens in mitral repair, obviously the first thing what you get is all your parameters, your wedge pressure, and your end systolic volume, end diastolic volume in mitral clip implantation that comes down drastically. So they have the group from Berlin, from Volkmar Falk and his group from Berlin, or that time he was in Zurich, actually showed that this is a very improved way of doing it. One interesting paper, one thing about mitral clip which you have to understand, if the coaptation length is less than 2 millimeters, it's actually a contraindication. But this interesting paper has actually showed if you increase the PEEP, the chances of coaptation length here is increased, but you have a decreased venous return, so there may be something challenging, and then your ventricle is less filled up. So once you have the coaptation point to increase, there's a good chance that you can put the mitral clip in place. So, and lastly, one more paper which I want to show to you. There's a group from Frankfurt who has actually compared mitral clip with without general anesthesia, with conscious sedation, and with general anesthesia. But there are some things which I want to show you. I don't think you can read it from there. But if you see that implantation of 2 clips was in general anesthesia, had no significance, they are almost the same. But the procedure time in general anesthesia was much less than in conscious sedation and local anesthesia, and the fluoroscopy duration was also more. So if you are doing a case where without anesthesia, you have to think of more fluoroscopy and more time in the operating room. But we usually extubate all our patients in the operating room itself, but they had a group where 100% was taken to the ICU. So the study design or the institutional design was completely different, and they could actually show absolutely no significance in any of the parameters undergoing general, local, or local anesthesia without sedation. So all the complications ratio was absolutely the same. So whether in the future, the way things are going to be done, we really don't know whether this patient can change this case series can change the patient management. I'm not sure, but as of now, we do it under general anesthesia using a very low dose of remifentanil and propofol, and we extubate with no muscle relaxants, but we extubate all our patients intraoperatively in the operating room, and our complications rate are probably much lesser than what they have published. So in conclusion, I would like to say that MIMS and mitral clip patients can benefit from a fast-track recovery protocol, and real-time 3D TE and fluoroscopy is actually a very good tool to communication between the cardiologist, the surgeon, and obviously the anesthetist. And post-operative assessment should be done even in the operating room under stable conditions. But otherwise, you may land up with a scenario where you're diagnosing SAM in an underfilled ventricle. So that can be something. And for this, and the last, I leave it for discussion for the house, whether the surgery or clipping in patient with high comorbidities, whether you are presently going for mitral clip or for minimal invasive mitral valve surgery, that is a question which will be answered in probably next 3 to 5 years' time. And thank you for your attention.